Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're in session number 5 of our new series entitled The QME's Clinical Rounds. And in today's session, we're going to begin part A of a 2-part series, which is going to be our final discussion in this program. And I have a fascinating discussion for you today that's going to help you certainly within 2 to 3 to 4 out of your next 10 cases as your examinees come to you for upper extremity complaints in and around the wrist and hand. And what I want to share with you today is a discussion regarding ulnar-sided hand pain, which is a very, very common occurrence in the injured workers that we evaluate. And so I'm sure that today's session is something that's going to be very, very helpful to you for the remainder of your career as a qualified medical evaluator. But before we get into the topics of today's discussion, let's just briefly review where we've come from so far in this session. In this program, we're talking about some common clinical conditions that you're going to encounter over and over again in your career as a qualified medical evaluator. And we began with the number one biggie that you're probably going to see more than any other subject of complaint in your examinees, and that had to do with carpal tunnel syndrome. And particularly with regards to carpal tunnel syndrome, there's one significant, highly significant clinical observation known as the flick sign, that when you observe your examinee to present with a flick sign, and the flick sign is simply a pain behavior that the examinee adopts in order to obtain relief from the numbness and tingling and congestion of bona fide carpal tunnel syndrome. When you observe this particular finding in your examinee, it's almost pathognomonic for bona fide carpal tunnel syndrome. And similarly, when you observe the absence or the omission or the missingness of this particular finding, it communicates to you greatly that whatever symptoms the examinee may be suffering from, they're not due to bona fide active and symptomatic carpal tunnel syndrome. So that was a fascinating discussion, and I provided you with a research reference for your enjoyment and for your study as to the research that supports the validity of the flick sign in the assessment of carpal tunnel syndrome. After that, we went on and we talked about some conditions of the spine. Particularly, we talked about the radiographic and diagnostic imaging finding of Schmorl's nodes. And you're going to see examinees with Schmorl's nodes. So we talked about what actually is the significance of Schmorl's nodes. Schmorl's nodes indicate a fracture of the vertebral end plates and a vertical herniation of the nucleus pulposus, either into the vertebrae superior or the vertebrae inferior. And so if you understand that this represents a serious injury to the spine, this represents either a finding related either to the current industrial injury, in other words, the current industrial injury caused the Schmorl's node, or this represents a prior and pre-existing condition of the spine. And in both cases, I provided for you several permanent impairment rating options that you can use to accurately rate these particular examinees for their loss of function of the spine. And then in session number 3, we went over some very fascinating facts and findings related to rotator cuff tendinopathy. And the principles that we discussed in that particular session relate to any form of tendinopathy throughout the body. Now, it seems that in the industrial setting, rotator cuff tendinopathies and elbow tendinopathies are the most common types of musculoskeletal conditions that examinees who are involved with cumulative and repetitive activities will present to you. And in particular, rotator cuff tendinopathy seems to be a pernicious problem among injured workers. So we talked about some of the microscopic changes that take place in and around the shoulder and in and around the rotator cuff tendons that create a situation where the tendon becomes degenerative and where the tendon will likely never recover to pre-injury conditions. So these are examinees who, once they develop the initial stages of tendinopathy, the tendinopathy tends to progress and fails to be able to recover. In part, that's due to limited treatment options in the industrial setting, and in part, it's due just generally to the degenerative nature of tendons. Once the internal homeostasis of the cellular environment of the tendon is disrupted, it just tends to degenerate like a locomotive running downhill. So for these examinees, I provided you several permanent impairment rating options. And really the take-home message from that particular discussion had to do with examinees who've undergone a surgical correction of the rotator cuff, or actually a surgical correction anywhere in and around the shoulder. The AMA guides provide for permanent impairment rating for one specific shoulder procedure, but you can analogize to any shoulder surgical procedure. You can analogize to a resection of the distal clavicle if you feel that that's appropriate. And this opens up a wide range of permanent impairment rating options for examinees who've had a multitude of various different types of surgical procedures in and around the shoulder, not just a resection of the distal clavicle. So that particular discussion was illustrative of the fact that you, as a qualified medical evaluator, have great latitude in providing for permanent impairment ratings for your examinees if you can simply explain how and why you arrived at your particular impairment rating. You can really employ many different types of creative impairment ratings as long as you can adequately justify your reasoning for providing that particular rating. And then in our last session, we went back to the spine. This time we went up into the cervical spine, and we talked about cervical ribs. And I shared with you a fascinating case example of an actual injured worker who suffered injury to the cervical ribs. He was involved in a front impact, high-speed motor vehicle collision, suffered a cervical hyperflexion injury, and part of the injury included injury to the C7, T1 section of the spine, segments of the spine, and he suffered injury to the cervical ribs themselves. And this resulted in a loss of motion segment integrity of the lower cervical segments of the spine, and I shared with you how these cervical ribs contributed to the injury, how the cervical ribs contributed to a generous permanent impairment rating due to the DRE Category 4 for loss of motion segment integrity of the cervical spine. And we discussed some of the different options that you have available in providing for your apportionment approximate percentages for an examinee who has pre-existing conditions of cervical ribs, who then suffer superimposed injury in the industrial setting. So that was a fascinating discussion. And all of these conditions, from carpal tunnel syndrome to cervical ribs, you're going to encounter these conditions in your examinees. Now, two of these findings, the Schmorl's nodes and the cervical ribs, can only be discovered when you order the appropriate diagnostic studies for your examinees. So you will never discover cervical ribs unless you take the time and exercise your initiative to actually order the diagnostic studies. And not all qualified medical evaluators do this. Not all qualified medical evaluators order the diagnostic studies. But in spinal cases, diagnostic studies are required for the assessment of permanent impairments of the spine. So these are conditions that you will discover, and in those cases wherein you do discover these conditions, I shared with you some permanent impairment rating options for those conditions. Now, in today's discussion, I want to talk to you about ulnar-sided wrist pain. Ulnar-sided pain on the ulnar side of the wrist. Now, this is a very common condition, and this is something that you may have some experience with yourself. Let me ask you, have you ever had ulnar-sided wrist pain? Are you familiar with the clicking and the clunking and the grating and the grinding that accompanies dysfunction of the ulnar aspect of the wrist? Well, if you've experienced this type of pain and clicking and clunking yourself, you know that it's a very disconcerting and very concerning type of condition. And so you're going to be experiencing this and encountering this in your examinees over and over and over again, especially those examinees that are involved in repetitious activities of the hand and wrist. And it seems that repetitious activities, including ulnar and radial deviation and pronation and supination at the wrist, predispose the wrist to ulnar-sided wrist pain. And as we're going to find, there is some significant changes that take place in the wrist joint itself as examinees age that lend the wrist to the development of ulnar-sided wrist pain. So I have a fascinating discussion to share with you today. So with that as our introduction, let's begin today's discussion on ulnar-sided wrist pain. Okay, so let's begin. Today we're talking about ulnar-sided wrist pain. Now, I want you to know that ulnar-sided wrist pain is a huge topic. There are complete books and complete reference materials that deal simply with the single condition of ulnar-sided wrist pain. So in today's discussion, I want to limit our focus to those types of conditions that you're going to encounter as a qualified medical evaluator. So we're going to investigate first some of the basic anatomy, and we're going to refresh our memory on some of the structures in and around the wrist. And this is going to be important for all of us who are not hand surgeons and hand specialists. We've all studied the hand, we've all dissected the hand, but we're going to go through a brief anatomy review, at least to the extent that it helps us understand the impairment ratings that are described in the AMA guides for examinees who suffer loss of function of the wrist. So we'll talk about the anatomy, and then we'll talk about the pathoanatomy, and we're really going to discuss really only two conditions that we commonly encounter as qualified medical evaluators, and that has to do with sprain of the wrist, involving a carpal ligament sprain or even carpal ligament tear. And then I want to share with you some information about the radiographic finding of ulnar variants and how ulnar variants can contribute to diagnosable conditions such as ulnar impaction syndrome and ulnar abutment syndrome. So in today's discussion, we're going to be talking about and investigating three types of conditions in the wrist. Number one, a wrist sprain in examinees who suffer late effect of wrist sprain. We're going to talk about ulnar abutment syndrome and ulnar impaction syndrome, both of which are influenced by either positive or negative ulnar variants. And then we're going to talk about permanent impairment rating options that you have available to you for accurately rating these examinees for their loss of function. And we're going to talk mostly in this program about how to provide for a permanent impairment rating due to carpal instability, whether that instability be of the dissociative carpal instability type or whether it be of the carpal instability non-dissociative type of carpal instability. Okay, so let's begin with a brief anatomy review of the wrist, and in particular of the ulnar aspect of the wrist. Okay, so let's have a brief review of the important bones and ligaments related to the wrist of the examinees that we're going to see in the California Workers' Compensation System. Okay, so just as a brief review, we have an image here, and what you're looking at here in this image is the palmar aspect of the right hand. So I want you to take your right hand, hold that out in front of you, and get your bearings as to some of these important landmarks in the wrist and hand. So here we have the distal ulna, here we have the distal radius, we have the ulnar styloid process here, the radial styloid process here, and then the wrist bones. If you remember the wrist bones, we have here the navicular or the scaphoid. This is the lunate. This is the triquetrum. Underneath the triquetrum here is the hamate, and on top of that is the pisiform. And then here we have the trapezium, the trapezoid, and the capitate. And here is a better view of the dorsal aspect of the hamate bone here. So in school you may have remembered the mnemonic or the lettering of the bones of the wrist by the mnemonic NLTP, which is the proximal row of carpal bones. That's the mnemonic to remember the proximal row of carpal bones. So that is the navicular, also known as the scaphoid, the lunate, the triquetrum, and the pisiform. And then we have the trapezium, the trapezoid, the capitate, and the hamate. So this is the distal row of carpal bones. So you can see that in the wrist, we have 2 rows of 4 bones, a proximal and a distal row. And then we also have 4 rows of 2 bones, considering both the proximal and distal carpal bones as they align up with each other. And then in between each of the carpal bones, there are the interosseous ligaments between each and every one of these carpal bones. And we can see that those are all depicted here circumferentially around the carpus. So important for our consideration and for the examinees that we're going to see are 2 important interosseous bones. One is the scapholunate ligament here, and here is the scaphoid bone here, and here is the lunate bone here. So here, this is the scapholunate ligament, and injuries to the scapholunate ligament are going to be relevant to us in terms of providing our permanent impairment ratings due to carpal instability. And the AMA guides specifically describe impairments related to injury to the scapholunate ligament. Okay? And then in addition, on the ulnar side of the wrist, we have the luno-triquetral ligament here, going between the lunate bone and the triquetrum bone here. And so you'll notice that with both of these ligaments are stabilizers of the lunate bone. So as we're going to see, the lunate bone here is central to the carpus and is central to injury to the wrist. Now, in addition to those interosseous ligaments, there are extrinsic ligaments that go from the distal ends of the radius and the ulna to various articulations and various bones within the carpus that are going to be involved in other types of carpal instability, not related to injury to the interosseous ligaments that cause a dissociative type of carpal instability, but rather due to injury to these extrinsic ligaments that cause a non-dissociative type of carpal instability. And we'll further define those terms in a couple minutes. So, for example, we have the ulno-lunate ligament here. We have a radio-scapholunate ligament here, which spans between the radius, a piece of the scaphoid, and then also to the lunate. And then we have some longer ligaments that go to the distal carpal row, such as the radio-scaphocapitate ligament here. We have here a piezo-hamo-capitate ligament that spans several articulations. And really, injury to any of these ligaments can cause wrist pain, loss of wrist function, and in particular, ulnar-sided wrist pain. So if we just divide this carpus into half and look at this aspect of the carpus, including the distal radial ulnar joint, we can see that here within this area are many, many structures wherein injury and loss of function can occur. So let's take a little bit closer look at the ligaments and also some of the other connective tissues in and around the ulnar aspect of the wrist. Okay, so now let's take a close-up look at the distal aspect of the radius and the ulna at the distal radial ulnar joint and take a look at some of the articulations at the distal radial ulnar joint and the proximal row of carpal bones. So here we have the distal radius, here we have the distal ulna, and remember that each of the ends of these long bones are covered in articular hyaline cartilage. So we can't really see that here on the distal aspect of the ulna bone, but just realize that it's covered with articular hyaline cartilage. Now the distal aspect of the ulna here articulates with the distal radius here at what's known as the sigmoid notch. So at the sigmoid notch, this is where distal radial ulnar pronation and supination occur. And of course, pronation and supination movements here are going to affect the activity of the proximal row of carpal bones as well. So here we have the ulnar aspect of the wrist, and look at how many structures are involved in the ulnar aspect of the wrist. And it's this area here where many of your examinees are going to report painful symptoms, and they're going to report clicking and clunking, whether it be painful clicking and clunking or whether it just be non-painful clicking and clunking, as these distal radial ulnar joint and proximal row of carpal bones suffer dysfunction as a result of an industrial injury. So let's take a close look at some of the structures involved in this ulnar aspect of the wrist. Okay, so now most medially here, and what we're looking at here is we're looking at the palmar aspect of this time your left hand. So just take a look at your left hand, the palmar aspect of it in front of you as we go through this diagram. So most medially in anatomic position here, we have the tendon of the extensor carpi ulnaris, which passes through a connective tissue sheath here to continue downward into its insertion in the hand. And then here at the distal aspect of the ulna, where the distal radial ulnar joint is here, we have both the dorsal and the palmar radial ulnar ligaments. So these are ligaments that are involved in stabilizing the wrist during wrist movements, especially during pronation and supination. And then, in addition, we have several ligaments that are involved in stabilizing the all-important triquetral bone on the medial aspect of the wrist. So as we discussed in our prior slide, we have here the Luno triquetral ligament, which is an interosseous ligament. Interosseous means it goes from carpal bone to carpal bone, connecting the individual carpal bones together. So it's interosseous ligament. So we have the Luno triquetral ligament. In addition to the Luno triquetral ligament, we have an ulno triquetral ligament here, going from the distal aspect of the ulna bone across the ulnocarpal joint to stabilize the triquetral bone here at the proximal aspect of the wrist. And then at the distal articular surface of the ulna, we have an articular triangular disc right in through here. Now the articular triangular disc is of varying thickness in individuals. Some individuals have a very thin triangular disc, whereas other individuals have a much thicker and more space-occupying triangular disc, because as you'll notice, the space between the distal aspect of the ulna and the proximal row of carpal bones here is all soft and connective tissues, consisting of ligamentous tissue and then this articular fibrocartilaginous disc. So this soft tissue space is variably filled by the articular disc. And in some individuals, the articular disc is thin, and in other individuals, the articular disc is thicker, and both individuals suffer susceptibility to ulnar-sided wrist injury. Okay, so these are some of the connective tissues and ligamentous structures in and around the wrist. Let's take a look at some of the neurovascular and articular structures involved with our wrist injury cases. Okay, and then in this diagram we have the ulnar aspect of your right hand. I'm sorry, the palmar aspect of your right hand. So take a look at the palmar aspect of the right hand. We have the radial artery coming down across the wrist and into the hand here, bringing blood supply to the thumb and all the way to the distal phalanges of each of the fingers. And then there is a circumflex anastomosis here, which makes an anastomosis with the ulnar artery here, passing through the palmar aspect of the wrist through the tunnel of Guyon, where it's accompanied by the ulnar nerve here, passing through Guyon's tunnel between the pisiform and the hook of the hamate here, and then bringing sensory distribution to the pinky finger here and the ulnar half of the ring finger over in here. And then here we have the median nerve passing through the carpal tunnel here and providing sensory branches and motor branches to the hypothenar muscles and sensory supply to the index, ring, and radial half here of the ring finger. I'm sorry, this is the index, this is the middle finger, and this is the radial aspect of the ring finger. And then in addition, around on the dorsal surface, serving the thumb web space, and the dorsum of the thumb is the superficial branch of the radial nerve, which also provides sensory supply to the distal aspect, the distal dorsal aspect. Here we have the palmar aspect, but if you can envision the dorsal aspect, bringing sensory distribution to the distal phalanges on the dorsal aspect of the hand. Okay, and then finally, let's take a look at some synovial cavities and some articulations involved with our wrist injury cases. Okay, and then what we have here is we're looking at the dorsal aspect of the left hand. Dorsal aspect of the left hand. So this over here is the left thumb. This over here is the left pinky finger. And so we're focusing here on the ulnar aspect of the wrist. So notice as we come down the radius and come down the ulna, we have the distal radio-ulnar joint here. And the distal radio-ulnar joint involves its own synovial cavity, separate and distinct from the synovial cavity of the proximal carpal rows. So this is a separate synovial joint in and of itself, the distal radio-ulnar joint, sometimes referred to as the DRUJ, distal radio-ulnar joint. So there's the distal radio-ulnar joint. And then as we cross the distal radio-ulnar joint into the proximal row of carpal bones, we have the radiocarpal joint here, where the radius articulates with the scaphoid and the lunate. And then we have the ulnocarpal joint here, where the ulna articulates also with the lunate and the triquetral bone. So this is the radiocarpal and ulnocarpal joints here. And then as we progress into the distal carpal row, we have mid-carpal joints between the proximal and the distal row of carpal bones. And let's change the color on that. We have the mid-carpal joints here, and notice that they have their own separate and distinct synovial cavities. And each of the carpal bones is covered in its own layer of articular hyaline cartilage. So these are all synovial joints of the carpus, and these synovial joints are subject to degenerative change. They're subject to injury, just as any other synovial joint throughout the body would be. Okay, so that's some of the basic anatomy structures that we're going to be involved with in dealing with our particular injured worker cases. Let's talk about now some of the types of injuries that we're commonly going to encounter as qualified medical evaluators. Now, the types of injuries that we're going to deal with as qualified medical evaluators can basically be divided into two basic categories, and those are the acute injuries and those are the chronic injuries. Now, with acute injuries, we're going to be dealing with ligament sprains, particularly sprains of the scapholunate ligament, strains of the Luno Triquetral ligament, and also strains of the radioscaphoid lunate ligament. Okay, these are the three ligaments that are going to be involved with both our dissociative and non-dissociative forms of carpal instability that are described in the AMA guides, and we'll talk a little bit more about these acute injuries here as we go. The second type of injury that we're going to see with our injured workers are the chronic type of injuries that are related to ulnar variants. And I'm going to define ulnar variants, and I want to share with you how ulnar variants and changes in the relative lengths of the radius and ulna bone can contribute to repetitive, overuse, and cumulative trauma injuries on the ulnar aspect of the wrist. So with regards to ulnar variants has to do with the relative lengths of the radius bone compared to the ulna bone. Now, in a normal wrist, a wrist with neutral or zero ulnar variance, the articular surface of the distal radius is congruent and confluent with the articulating surface of the distal ulna. So in this case, we say that the radius and the ulna have the same lengths, and there's no variance. There's neutral variance, zero variance between the lengths of the radius and the ulna bone. Now, in contrast to that, as the length of the ulna bone varies, we see circumstances where the ulna bone has a longer length and a positive variance, meaning that its articular surface of the distal ulna bone is distal to the articular surface of the radius bone. Those are cases that involve positive ulnar variance. And then cases that involve negative ulnar variance are where we see that the articular surface of the ulna bone is proximal to the articular surface of the radius bone here, and there's a variance or a differential in the length of the radius bone compared to the ulna bone. Those are cases that involve a negative ulnar variance. Now, both of these circumstances, whether it be positive ulnar variance and negative ulnar variance, can predispose the wrist to various types of injury as the distal radial ulnar joint here becomes affected by changes in the length of the ulna, and as the ulnar carpal joint here becomes affected by, again, varying lengths of the ulna compared to the radius bone. So we're going to investigate how ulnar variance, whether it be a positive ulnar variance here or a negative ulnar variance here, how those various findings related to the length of the ulna bone can contribute to these various injuries and repetitive strain, cumulative trauma types of disruptions of the ulnar aspect of the wrist. So let's talk a little bit more about ulnar variance. To determine ulnar variance, and we're going to look at a wrist x-ray here in just a moment, we're going to draw two lines. The first line is a line tangential to the articular surface of the ulna, which is here, and perpendicular to its shaft. And then another line is tangential to the lunate fossa of the radius bone here, and also perpendicular to the shaft. And the distance between those two lines is measured. So normally the distance between those two lines is 0. But in cases where the ulna line projects distally compared to the radial line, we have a positive ulnar variance, and where that line projects proximally compared to the distal radius, we then have a negative ulnar variance. Okay, so let's go through an actual x-ray image and make some of these measurements ourselves. Okay, so here we have a P to A view of the right wrist. So just take a look at the back of your right wrist as you put your right wrist in front of your face. Will help you get your bearings regarding some of these landmarks. And let's just blow this image up and make our assessment as to positive or negative or neutral ulnar variance. So here we have a blow up of the distal radial ulnar joint. Here's the sigmoid notch here. And in assessing for ulnar variance, our instructions are to draw two lines. So the first line is a line tangential to the articular surface of the distal ulna. And that line must be perpendicular to the shaft of the ulna. So this must be roughly a 90-degree perpendicular angle. And that angle is 91.5. So there's a 90-degree angle right about there. Okay, so there's our first line. And then the second line is perpendicular to the lunate fossa of the distal radius bone. So here is the lunate fossa. Let's extend that line down and perpendicular to the ulna bone here. And there is a 90-degree angle there. Okay? Now if we blow this up even further and we measure the distance between these lines, we see that the distance between these lines here and here is approximately 1.1 millimeters. In fact, if we reassess our initial line here on the ulna and raise that up more tangential to the articular surface of the ulna, we see that the ulnar variance is possibly greater even than 1.1 millimeters. Okay, so this would be a 1.1 millimeter positive ulnar variance. Now this ulnar variance is going to affect the integrity of the distal radial ulnar joint here and create some conflict in the congruity between the sigmoid notch of the radius and the articular surface of the ulna here. It's also going to impact this space where the connective tissues, including the articular disc and the triangular fibrocartilage, fill up this space here within the ulnar carpal joint. So in situations where the distal ulna is longer than the radius, in other words, we have a positive ulnar variance, this space is going to be compressed, compacted, and compromised compared to a situation where we would have a negative ulnar variance. Now, interestingly, ulnar variance can change with various circumstances, including aging, and then also with positioning of the wrist. So within this same examinee, let's take a look at what happens to the ulnar variance in this particular examinee as the examinee forcibly clenches and contracts the tissues and the muscles and the tendons crossing the radiocarpal and ulnar carpal joints. So here we have a closed fist stress view. Again, we're looking at the dorsal aspect. This is a P to A right wrist. And if we blow this up, we note that under contraction and under loading, the wrist ulnar variance here actually increases. So that if we draw our lines, here's the perpendicular line, here's the tangential line, and we'll draw that so that the angle is roughly 90 degrees, and there's exactly a 90-degree angle. And then we do our radial line and draw a line perpendicular to that across the lunate fossa here. And we make sure that that's a perpendicular line at approximately 90 degrees. And if we blow that up even further, and we make our measurement here of the ulnar variance, we can see that the ulnar variance has increased from 1.1 to approximately 1.8 or even 2 millimeters of ulnar variance. And you can see that there's compression here taking place at the ulno-lunate joint. There's compression taking place here at the ulno-triquetral joint here. And the connective tissue spacing in here, including the articular disc and all of the ulnocarpal ligaments here, are being compressed and impacted and compacted as the space becomes compromised due to this positive ulnar variance. Okay, so let's take a look at a couple of models that depict these various possible configurations of the ulnar variance, being the positive ulnar variance, the neutral or zero ulnar variance, and the negative or minus ulnar variance. Okay, so here we have a table that depicts how forces are transmitted across the radiocarpal and ulnocarpal joints depending upon the variance of the ulna. So in the normal situation where we have a neutral ulnar variance, meaning the articular surface of the distal ulna and the distal radius are congruent and that there's no differential between those tangential lines, with neutral ulnar variance, we see that 80% of load-bearing forces pass through the radius, where only 20% of load-bearing forces are transmitted through the ulnocarpal joint. So this would be the radiocarpal joint. This would be the ulnocarpal joint. It's about an 80 to 20 ratio. 4 times the amount of load-bearing force goes through the radial aspect of the wrist, and only 20% goes through those sensitive connective tissues such as the articular disc, the articular fibrocartilage, the triangular fibrocartilage, and the medial wrist structures. Well, as we start to get a positive ulnar variance situation where the length of the ulna becomes progressively longer than the relative length of the radius bone, then we see an increasing amount and an increasing percentage of forces being distributed now through the ulna, with 30% of the load in cases of a 1 millimeter positive ulnar variance. In the case that we just saw, we had between a 1 and 2 millimeter positive ulnar variance. With a 2 millimeter ulnar variance, we're seeing a doubling of the load-bearing forces being transmitted through the ulnocarpal joint as is transmitted through the ulnocarpal joint in cases with a neutral or zero ulnar variance, and a corresponding diminution in the load-bearing forces through the radiocarpal joints in cases of increasing positivity of ulnar variance. On the other hand, in cases that involve a negative ulnar variance, what we see is an increasing proportion of forces now going through the radiocarpal joint. This is at the radiolunate articulation, the radioscaphoid articulation. Okay, we're getting more towards the radial side of the wrist. But also we can have injuries at the division line between the radius and the ulna here at the radiolunate articulation, and even into the distal row of carpal bones at the radiolunocapitate articulation. And then we see a corresponding decrease of forces here being transmitted through the distal ulna. But as we're going to see with with ulnar impingement syndrome, we're going to see an increasing distribution of forces and aberrant forces being distributed through the distal radio-ulnar joint. So that's not depicted on this particular table, but it's cases where there's a significant negative ulnar variance that we see pathology develop not at the radiocarpal or ulnocarpal articulations, but at the articulation between the radius and the ulna at the distal radio-ulnar joint. This is the ulnar impingement syndrome. Okay, so how do some of these findings of ulnar variance vary with age, and how is ulnar variance going to affect our aging population, and in particular our aging injured workers? Well, let's take a look at that now. Okay, and this is from a study entitled Normal Age-Related Alterations on Distal Radius Radiography. And this is a 2015 study from the Archives of Bone and Joint Surgery. And what this table depicts is that in young individuals, say between 2 and 20 years of age, radiographs and measurements of the distal radio-ulnar joint indicate that young individuals typically have a negative ulnar variance, meaning the length of the ulnar bone is significantly shorter than the length of the radius bone, significantly shorter. This would be a neutral ulnar variance where the lengths are identical. With a negative ulnar variance in younger individuals, in very young individuals, the negative ulnar variance is significant, up to 2.48 millimeters, diminishing to approximately 1.6 millimeters as adolescents approach skeletal maturity. Thereafter, in skeletal maturity, with ages 20 through 29 and progressing all the way up through ages 40 to 49, we're starting to see an increase in the positivity of the ulnar variance, with those ages between 20 and 29 having approximately 0.85 millimeters of positive ulnar variance, contributing to increased abutment and impaction syndrome on the ulnar side of the wrist. Then between ages 30 and 39, we see an increasing positivity in the ulnar variance, peaking between ages 40 and 49, where the ulnar variance is as high as 1.35 millimeters, similar to the case that we just measured on actual X-ray. And then ulnar variance diminishing in individuals over 50 years of age. So here are your high-risk populations for the development of ulnar-sided wrist pain. And doesn't this look a lot like the examinees that we have in the California Workers' Compensation System? So, like we've discussed in other programs related to the shoulder undergoes bony architectural changes with aging, and in particular, the shape of the acromion process actually changes with aging. Isn't that amazing? You know that we talk about the different types of shape of acromion processes as either being type 1 acromion process, type 2 acromion process, type 3 acromion process, and those descriptors refer to varying downsloping degrees of the acromion process of the scapula. Well, recent studies are indicating that changes in the sloping, the downward sloping of the acromion process accompany normal degenerative changes with aging. Isn't that amazing? And this may have to do with traction forces on muscles and pull on ligamentous structures over the years and the decades. And the researchers aren't exactly clear as to what is the causes of the changes in the actual architecture of the bones. But what we see in the shoulder here, we also are seeing in the wrist, and that the wrist undergoes actual bony changes in the lengths of the bones as individuals age. And we're going to find this in our injured workers in our qualified medical evaluations. And that is that older workers have an increasing positive ulnar variance at the wrist, and this in particular related to those examinees who are involved in repetitive activities. This is going to contribute to the development of ulnar-sided wrist pain. So ulnar variance is one of those X-ray measurements that you're going to want to pay particular attention to in the assessment of your examinee, and you can only do these measurements when you actually obtain the necessary radiographs, the necessary diagnostic studies to assess for the presence or the absence of ulnar variance. Now, in our next session, we're going to talk about how you can additionally use your X-rays that you obtain for the assessment of your examinee in assessing for permanent impairment due to our other diagnosable condition that we want to discuss, and that has to do with ligament sprain. Ligament sprains and ulnar variance conditions in your examinees are going to leave your examinees with permanent impairments. And we're going to talk about how the X-rays can be used to determine the permanent impairments in your examinees, whether they have an actual ligament sprain acute injury or whether they have a chronic repetitive cumulative trauma type of injury due to either positive or negative ulnar variants. So those are the topics that we're going to go over in our next session as we continue with our new series entitled The QME's Clinical Rounds. And we're finishing up this program with session number 5 related to ulnar-sided wrist pain. And in our next session, we'll be in session 2 of this same discussion. So for today, this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's discussion. I hope this discussion helps you in your assessment of wrist pain cases. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.